بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. أعزائي الطلبة، أتمنى أن تكونوا بصحة وبسلامة أنتم وعوائلكم جميعا. Hello everybody, I hope all of you are fine and in good health, you and your families, and I hope we will meet again in the very near future because of the circumstances that you all of you are aware about. We have no other way to continue learning than to connect with you through all these media. So I hope that you find this helpful to cover at least the most important aspects in clinical ophthalmology. As we usually start in ophthalmology, just like the beginning in any branch of medicine, ophthalmology is not an exception. You start your examination, you start by taking history. Of course, you have to ask the patient about his or her name, the age, because certain diseases affecting certain age groups, and also you have to know the residence and the contact details of the patient and so on. Then you have to know the chief complaint and its duration. As you know, the chief complaint is the cause that made the patient seek medical help, and usually we put it in a very short sentence, and you can use the terms which is used by the patient. Also, this is followed by the duration. So you have to tell the chief complaint and its duration. For example, I have pain in the right eye for 2 days, or there is redness in the left eye for 2 weeks, or there is a blurring of vision in the right eye for the last 1 month. So just you tell the complaint and its duration. After that, you need to go in details about the history of present illness. You have to know the details. If the patient is having, for example, blurring in vision, then you need to ask, is it sudden? Is it gradual? Is it associated with pain, or it is just paleness? All these are very important. Any association with redness in the eye, discharge, for example, and so on. It's very important to have a good idea about the previous history of the patient, whether it is ocular or medical. You need to ask the patient about any previous diseases, for example, diabetes mellitus and hypertension. It's very important to inquire about diabetes mellitus, and you have to know the onset of diabetes, for how long the patient is having diabetes, and also the glycemic control. These two factors are very important because we have the complications of diabetes on the eye on the top of the list, or the most important is the diabetic retinopathy. But remember here that the duration is not always true, because sometimes the patient tells you the time of diagnosis, which is not necessarily the time of onset of the disease. Sometimes there is late diagnosis. The patient probably is having diabetes for 5 years actually, but the diagnosis was just before 1 year. In this patient, you may examine the eye, you may find diabetic retinopathy, yet the patient is giving you a history of diabetes mellitus for just 1 year. But in this condition, it is definitely late diagnosis, because diabetic retinopathy needs at least 5 years to develop. Then you have to know the previous history of the patient about the eye problems. It's very important to know, is there any previous eye diseases like glaucoma, for example, any previous surgeries in the eye, and also you need to look for any medical treatments. I mean, any drug history. Drug history is very important if the patient is already on anti-glaucoma, for example, or any other medications. After that, we need to start our examination. As ophthalmologists, we start our examination by checking the visual acuity. When we want to check the visual acuity, we use a chart. We call it a Snellen visual eye. This is the chart, and we ask the patient first to see if to check if he can see the first letter or not. The first letter, if you look here, there is 660 in front of the letter at the top of the chart, and then we go down until we reach 66. So we ask the patient, can you see this letter? Can you read this letter? And we can use, other than this, we can use all these letters as E letter, and we just ask the patient to denote the direction of the E, to the right, to the left, up or down. And we ask the patient, can you see this letter or the direction of the letter? Suppose that the patient can see with the right eye only these letters. So we will label the right eye as 6/36. What does that mean? The first number, which is the 6, it's the distance between the patient and the chart, which is fixed, always 6. But the next number, this is the distance at which a normal person can see that letter. So when the patient sees 6/36, it means that the patient is sitting at 6 meters, but he or she can only see the letter, which should be seen by a normal person at a distance of 36 meters, and so on. If the patient can see these letters only, then we can say that this patient is seeing 6/18, which means that the patient is sitting at 6 meters, and he or she can only see the letter which is seen by a normal person at a distance of 18 meters, until we reach 66, which is the normal visual acuity. So simply, this is the Snellen chart, which is used for the assessment of the visual acuity in adult, and we can use it in children 4 years and above. After we take the visual acuity, then we proceed with our examination. The most important instrument which we use it in our daily clinical practice, what we call it the slit lamp, or the slit lamp biomicroscope. This is a very important machine which has been invented by Goldstrand, a scientist who invented this machine. No proper ocular examination can be performed without this machine. So we need to know the basic parts of this machine. We have 3 main parts. This is the viewing arm, this is the illumination arm, and this is the patient positioning frame. This is the viewing arm, which contains the eyepieces. Actually, it is a microscope, and we call it biomicroscope because we are using this machine to examine a human being, living human being. So we call it biomicroscope. This is the eyepieces, which is used by the examiner to look through. And here we have a magnification set. We can magnify the image which is seen. We have a lever here. Or sometimes there is knob. We can just rotate this knob, and we can change the magnifying ability of the slit lamp. Again, we have the illumination arm. This is the illumination arm. Here there is light source, and this light source will illuminate through through this path, will pass through filters, set of filters, and then here we will have a mirror. This mirror will reflect the light towards the eye of the patients. The idea or the purpose of putting these filters here, we have a cobalt blue filter. A cobalt blue filter, when we turn this on, it will change the light from white to blue light, what we call it cobalt blue filter. This is important when we want to visualize any epithelial defects, any ulceration, provided that we have used a special stain. We call it fluorescein stain. Okay. Again, we can use this filter when we want to check the intraocular pressure. Again, we will use a stain which is the fluorescein stain. So this filter is usually used with a stain to visualize the lesion, which is most importantly the corneal ulcer. Also, we have another filter, we call it red-free filter. This red-free filter will change the light which come through the illumination arm from white to green. We call it red-free filter. This is important when we want to see when we want to examine the nerve fiber layer in the retina, and also visualization of blood vessels is better by using this filter. Again, the illumination arm, we have certain knobs. One is here and the other is here. We can change the height of the slit, the beam of light which passes, or which we use to examine the eye. We can enlarge either the height or the width of the beam. This will change the width of the beam, and this will change the height of the beam. Then we have the patient positioning frame. This is the part of the slit lamp where the patient put his or her chin here, and this is the forehead strap where the forehead of the patient come in contact. We need to adjust the position of the head of the patient here. If you look carefully, this is a black line here. This line should be aligned with the canthal angle, with the lateral canthus, which is the lateral angle of the palpebral fissure. So this should comes in alignment with the eyes of the patient. Okay. This illumination arm, it could be rotated from side to side without affecting the focus. The light always comes in focus with the viewing arm. This is the base of the slit lamp, and here we have the joystick. By using this joystick, we can elevate or we can adjust the height of the whole slit lamp up or down to make the beam comes directly to the eye of the patient. Okay, and again, we can, by using this joystick, we can move the slit lamp forward or backward, and this will affect the focus of the image of the eye. So you can push forward or backward until you get the eye in focus. This is the picture of the slit lamp. Here is the viewing arm, here the illumination arm, and this is the patient positioning frame. Another thing, if you look carefully here, this is what we call it the Goldman applanation tonometer. So the question now, what are the uses of the slit lamp? The slit lamp is used to examine the anterior segment. It is used to examine the posterior segment, but with added lenses, you have to be careful when you mention this use of the slit lamp. The slit lamp alone cannot we cannot see the posterior segment. What we mean by posterior segment is the posterior 2/3 of the vitreous and the retina, what we call it the fundus. So the posterior segment cannot be seen by the slit lamp alone unless we use added lenses. Again, the slit lamp can be used to check or to measure the intraocular pressure by using Goldman applanation tonometer. This is the Goldman applanation tonometer, which is used to measure the intraocular pressure. What are the added lenses which is used with the slit lamp to examine the posterior segment? We have a lot of lenses, but the most important lenses which is used is the plus 78 diopter lens. This lens is used with the slit lamp to visualize the posterior segment. Here the image will be seen as inverted and upside down and laterally reversed. The image here is seen laterally reversed and upside down. The right will be left, the left will be right, the upper will be in lower down, and the lower part will be in upper position. So this is, we call it the plus 78 diopter lens. Another lens which could be used to examine the posterior segment, we call it the 3-mirror contact lens. This is the 3-mirror contact lens. This is the central part, which this is the central part. Again, this is another view for the same lens. This is the part which comes in contact with the cornea of the patient. Of course, we have to put topical anesthesia, and we put viscoelastic substance here. We shouldn't make any air between the lens and the cornea of the patient. And then we bring this lens in contact with the cornea, and then we start visualizing the eye through this lens. This is the central part through which we can see directly the posterior 30 degree of the fundus. So we can see the optic disc and the central part of the retina. If we want to see the peripheral retina just away from the central part, which is seen by the central lens, we can use this lens. So this lens will show us the mid periphery of the retina. And here we shouldn't look through the central lens. We have to look through this mirror, because this mirror will show us through the central lens to see the retina in this side. When we want to see the retina here, we have to rotate the lens while it is in contact with the eye of the patient. So we will rotate gradually 36 degrees so that we can see the whole mid-peripheral retina. If we want to see the far periphery of the retina, then we can use this mirror, because the inclination of the mirror here is different. So we can look through this mirror to see the peripheral retina. And again, we will rotate until we can see all the whole parts of the retina. The third mirror here, which is dome-shaped mirror, this mirror through which we can see the angle of the anterior chamber. So this mirror is not for the examination of the posterior segment. This mirror can show us the angle of the anterior chamber. What we mean by the angle of the anterior chamber, it is the angle between the cornea anteriorly and the iris posteriorly. So these are the most important uses of the slit lamp. Definitely there are a lot of uses, but these are the primary uses. Other uses of the slit lamp, it could be used to deliver laser to the eye when we want to. Different types of lasers could be used through the slit lamp to deliver. So here the use will be therapeutic and not diagnostic. Also in capturing images, whether for the anterior or the posterior segment of the eye, again certain cameras could be incorporated to the slit lamp to make this function. Now we can see some of the most important cases that we are dealing with in our daily practice, and to see how the patient presents and how it could be he or should or she could be managed. Okay. This is a colored photograph showing the left eye of this patient who is presented with subconjunctival hemorrhage, which is seen in the upper part. We call it below the upper bulbar conjunctiva. Also, we have blood in the anterior chamber. We call it hyphema. In addition to that, we have dilated pupil. Again, we need to know the cause of this dilatation in the pupil, whether it is caused by drugs to dilate the pupil, or this is due to the trauma, whether the trauma to the iris itself, we'd call it traumatic mydriasis because of the injury to the sphincter pupillae, or the trauma involving the optic nerve. And here we have to make sure whether the patient can see the light or not, because as we have said, when there is trauma to the optic nerve, there will be no light perception. The question here is what could be the cause of this subconjunctival hemorrhage, the hyphema, and the dilated pupil? Most probably the answer is trauma. What is the most important step in the assessment of this patient? We have to check the intraocular pressure. Intraocular pressure assessment or measurement is very important. And what do you expect the intraocular pressure? Is it going to be high or low in this patient? The answer is we expect the intraocular pressure to be high. Why? Because the blood in the anterior chamber is going to be engulfed by macrophages, and these macrophages can occlude the small spaces in the trabecular meshwork, which is located in the angle of the anterior chamber, which is the site of drainage of the aqueous humor. So the patient will have increased intraocular pressure due to the poor drainage of the aqueous humor. So we expect the intraocular pressure to be high. And this is in any case of hyphema. You shouldn't let a patient with hyphema to leave your office unless you check the intraocular pressure. Suppose that you have checked the intraocular pressure of the patient with hyphema with history of trauma, and you found the intraocular pressure is very, very low. The eye almost has lost its tension, hypotony. So what do you think in this situation? Here, when we have a very low intraocular pressure with history of trauma and there is hyphema, so a wound in the sclera or puncture in the eye must be suspected. Okay? So we have to exclude any wound, any penetration, ocular penetration, which could be the cause for this hypotony in the eye. Because as I have said, when there is hyphema, we expect the intraocular pressure to be high, not low. This is another picture showing a very common problem. We see it in our daily practice. This is what we call it pterygium. There is fibrovascular tissue growing from the conjunctiva toward the cornea. It covers the reaching almost the center of the pupil and definitely cosmetically unaccepted, and also it will affect the vision of the patient and also it will affect the lubrication of the cornea, because when the eyelid moves over the cornea, this part of the cornea and this part of the cornea will not be lubricated perfectly by the smooth edge of the lid, because this margin of the lid, when it moves up and down, it is going to lubricate the cornea. So this patient will complain of poor vision and also will complain of symptoms of poor lubrication of the eye. So the patient will complain of foreign body sensation, pain, and so on. In addition to that, there will be the shape of the eye cosmetically unacceptable. What's the treatment here? The treatment is surgery. We have to excise this part of the conjunctiva. So this is what we call it pterygium. This is another slide showing foreign body in the anterior chamber. So this is foreign body in the anterior chamber in front of the iris. Okay, definitely this foreign body has entered to the eye through wound in the cornea, in the periphery of the cornea or any part in the cornea, and comes here in the front of the iris. Definitely the treatment here is surgical. We have to make very small wound in the periphery of the cornea, and then we just take this foreign body out.